So first of all, thanks a lot, Ganna, for joining us today. Ganna is an assistant professor at the University Medical Center Utrecht in the Netherlands. Prior to that, she earned her PhD in theoretical physics from University of Lisbon and was a postdoctoral research at the University of Manchester. For both positions, she obtained personal fellowships from the Portuguese Foundation of Science and Technology. Her research centers on the application of infectious disease modeling to answer questions and support evidence-based policymakers in public health. Ganna is interested in emergence, evolution, and spread of infectious diseases, as well as assessing the impact of intervention, such as vaccination, treatment, and on transmission of the diseases. Specific applications include HIV, SARS-CoV-2, influenza, CMV, and childhood infections. Her studies on the control of COVID-19 helped to guide policy in the Netherlands and Portugal and were highlighted by international and national media. So Ganna, the audience is yours. We are looking forward to hearing from you. Thank you.
Oh, thank you very much for the introduction, Myra. I'm really happy to be here. I'm one of the persons who I think is a regular attender of your workshop that you have been organizing for many, many years. And I hope that already next year that will be probably in presence. And and it's really nice to be able to still, to tell about the work I have been doing with collaborators also on the COVID topic. So let me start. So I would like, first of all, to acknowledge all people with whom I have been working on this topic. And these are mainly researchers from Lisbon University, where I did my PhD, as Myra said, and my colleagues from the University Medical Center Utrecht. And here's the list of all people who have been involved in the specific two studies that I will present today. And most importantly, I think that we have on the team people who are actually very close to policymakers. In the Netherlands, this is Manuel Gomes. He is the member of the COVID-19 vaccination committee in Portugal, and he's one of the main advisors for the COVID pandemic for the Ministry of Health. That's one of the reasons why the project also has been supported by the Ministry of Health of Portugal. And in the Netherlands, I work with Mark Bonten, who is the member of the outbreak management team in the Netherlands, who is advising the Dutch government. And the studies, I will present you two studies, and I separated my talk like in two parts, which is called Study 1 and Study 2. The first study is a study about the impact of school and non-school related measures on the pandemic in the Netherlands, and it's already been published. So, and here is the reference. And the second study, it's not published yet. The preprints are available from both Research Square, and also we double posted on medRxiv. And the preprint, the manuscript was submitted to Nature Communications, and well, actually we expect that it will be published rather soon, but it's not there yet. And in the spirit of open science, we share everything that we do on the GitHub, so you can find everything on my GitHub for the both studies. And because this is quite a sensitive topic, and I would like just to mention that the work got a lot of attention in the media, in particular in the Portuguese media, but also in the Dutch media for both studies. So I'll start with the study about the impact of school-based transmission in the Netherlands. And to give you a background, of course, we all live, we live in the COVID era, so that we know a lot about COVID, but what specifically do you need to know to understand my talk? The study was done at the end of 2020, just in autumn 2020, when the Netherlands was going through the second wave of COVID pandemic. And there was a lot of discussion going on what is the role of school-based contacts in the epidemiology of SARS-CoV-2, how much do schools contribute to transmission? And there was a discussion whether schools actually should be closed during that second wave. And of course, there is still high priority to keep schools open for many reasons, but it's not clear, how to do that while still have the control of the pandemic. And in our study, we addressed a few questions. So the first was, what is the effect of schools-based measures, including the school closure during the course of the pandemic? If we want to keep schools open, how do we need to reduce, or by how much do we need to reduce contacts in the rest of the society to keep schools open, but still have the control of the pandemic? And specifically, we would also like to know what is the importance of different school ages, because there are elementary schools, there are kindergartens, there are secondary schools. So it was important at which school ages do the interventions have to be targeted mainly. And I'm an infectious disease modeler, so we used the transmission model. It's quite a simple model. You will recognize it's basically SEIR model, in which the population is stratified into different categories, shown here as different boxes. So there are individuals who are susceptible, who never experienced any infection with SARS-CoV-2. Then these individuals, upon infection, they become latent, so they are infected but not yet infectious in this box. Then after some time, they progress into the infectious state, and the infectious states, they are shown here as red boxes. We distinguish among a general number of boxes, what can be M, so M infectious stages, but the models can be simplified to having also one infectious stage, which would be a standard SEIR model. And then after being infectious, the individual recovers and then doesn't participate anymore in transmission. And from the infectious stage, what's important, we distinguish all people who recover without having a severe disease. So those who are completely asymptomatic or have mild symptoms, and there are individuals who also recover through going to the hospital first. So the people can be hospitalized with a certain rate and go into this age box. And index K denotes that it's an age structured model. So we have, in general, we have K age groups. Red boxes are people who participate actually in the force of infection, which is shown here with red arrows. Individuals have also dependent on the age group, they have different susceptibility, and beta K denotes the reduced susceptibility with respect to our oldest age group. Well, what else should I mention? So we introduced these several infectious stages to be able to distinguish between different types of distributions for the infectious period. So when we have just one box, that's the standard model with the exponentially distributed infectious period. But as we increase this number of boxes, the distribution of the infectious period becomes more peak or gamma-like. And when the number of infectious stages is infinite, we would get a fixed infectious period. So just to give you an idea how the model is stratified, we have 10 age groups, so groups of 0 to 4, 5 to 9, etc. years old, and everybody who is older than 80 is grouped into one age group. And then we use only 8 hospitalization classes. So because there are a few number of hospitalizations among the youngest individuals, we group the 0 to 4, 5 to 9, 10 to 19 into one age group, so 0 to 19, and then you end up instead of 10 with 8 hospitalization groups. We have 3 susceptibility classes, so the susceptibility is determined for individuals between 0 and 19 years old, 20 to 59, and everybody who is older than 60, and the reference class is individuals who are older than 60, and this is supported actually by the literature already and by a lot of different observational and cohort studies overall. And we used, in this specific results that I will present, we used the 3 infectious stages. And the model was just given by a set of differential equations. I wouldn't like to go too much into the detail, but if you would like to see how they look like, they're here. The force of infection, importantly, in age group K, which is denoted as lambda K, it's of course time dependent, and it depends on the number of contacts between the individuals in age group K and number of individuals in age group L, and the proportion of people, infectious people in the age group L. So it's age specific, and epsilon is the probability of transmission per contact. So we used in this specific study, we used the contact matrices for the Netherlands. Netherlands has conducted several surveys in which the contact structure has been measured throughout the pandemic. The first the first contact matrix, which is before the pandemic, we used the data from 2016 to 2017, which is shown here. So these are different. On the y-axis are the different age groups of the contacts, and on the x-axis are different age groups of the participant. And each entry in this matrix gives the number of contacts, one person, so one participant in a given age group, for example, 5 to 10, reported with participants in 5 to 10, for example, 5 to 10 age group, and so on for the other entries. And you see that this number of contacts reported varied between, well, nearly 0, which is shown as light color, to 9.3, roughly. Then we used, so the same contact matrix is available for the school settings, specifically for the contacts taking place in schools. And here you can see that, for example, that many of the entries they don't have that many contacts, but there is this very clear diagonal pattern, because children who are with ages, for example, 5 to 10, have most of the contacts at school was also with 5 to 10-year-olds, and the same is true for 10 to 20-year-olds. And to some extent, this pattern is also seen in the total contact matrix, because children have the largest number of contacts overall in the population among different age groups, if you look. Then we also used the contact matrix, which was evaluated after the first lockdown was introduced in the Netherlands. And the first lockdown was introduced in mid-March, roughly. And in April, when the country was in the full lockdown, this contact matrix was measured. And here it's shown, as you see, that the contact structure changed. Also, the average number of contacts, or the maximum number of contacts, also between two age groups, was reduced very much. Here's the maximum 9.3, and here's 1.5. And overall, roughly by 70%, the contacts were reduced in the population, much more for the youngest individuals because the schools closed, and to a small extent for the older individuals, because the older individuals, they already have essential contacts. So we use these contact matrices in our analysis. And I think one of the things that we are doing differently from many infectious disease modelers is that we actually model the transition, how the transition between these different contact matrices happen. So how did the contact structure actually change with time? And to do so, instead of imposing when the transition happens, we estimate how it happens. So what we do, we say that, well, there is a general contact rate, let's say CKL, and we say that this general contact rate, it's dependent on time, and it can be written as a linear combination of the contact matrix before the lockdown and after the lockdown, which I just showed to you before. So this one before the lockdown, and this one is after the lockdown. And there are coefficients for this linear combination, 1 minus ft and ft. And f of t is just a logistic function, which is defined by two parameters, k1 and t1. And here's an example of logistic function shown here on the right-hand side as red, for example. You can see it's a function that changes between 0 and 1. And k1 determines the slope of this function, and t1 determines where is the midpoint, is where the value of the function would be equal to 0.5. So what we do is that we estimate this K1 and T1 from fitting our model to the data. And here's a median estimated trajectory, red, as you can see, and the gray are this individual trajectories estimated from the data. So you see that sometimes the timing can be a bit different, but also the slope can be a bit different. And we use this procedure also to see how the contact structure would change after the lockdown is released. And in particular, when the schools open, we can proceed in exactly the same way as before. And we can say, well, that the contact rate, instead of changing from the matrix B into the matrix A, which is considered here, we assume that we start with this matrix, which was the contact structure that we have after the lockdown, which is zeta1, AKL, and we transit into another contact structure, and that's split in two. We separately consider schools, so that's the school contact matrix, and omega is the proportion of contacts at school. And the rest of the contacts can be obtained because the structure is additive. It's the number of contacts before the lockdown minus the number of schools, and times the coefficient, which is again, like here we have 1 minus f times f, and here we have g minus g. So the point is that we can model how the contact structure changes with time, and all the parameters are also estimated. And probably one thing that I forgot to mention is that why there is another parameter zeta1 here. Well, because we use the real contact structure, and people sometimes after the lockdown, they report contact is effective reduction in transmission that is not seen in the contact structure, and then this parameter is captures that, so it's zeta1. So the model is fed to 2 data sources. I mean, we use different like demographic data and so on, but the formal fitting is done to 2 data sources, and that's age-stratified hospital admissions. And this study was done just for the first wave, so we used 69 days after the first case, which was 27th of February in the Netherlands. We assume that the epidemic started actually before the 20th, before this first case officially was announced. And we estimate the number of hospitalizations 5 days before that official case. So it's also not imposed, it's also estimated, and we assume, so this estimation done on February 2022. And then we fit also at the same time to the age-stratified serological data. And the serological data was collected after the first wave. So, and the median date of the serological data was April 1st. That's what is used in the model. The prevalence was still relatively low at that time, was 2.3%. And we use a Bayesian framework just to fit our model. So to give you an idea, so that's what we get from this model fit, we get parameter estimates for all our parameters, and these are different distributions. For example, that's the probability of transmission per contact that I mentioned, epsilon, and we estimate that it was roughly 7%. That reduction in probability of transmission per contact due to mask wearing and so on that I mentioned, it was about 50%. The latent period is estimated at 2.5 days, and the infectious period is estimated at almost 5 days in the model. So by using these different parameter estimates, we can then generate what the dynamic of the epidemic would be. Most importantly, for the study on schools, we estimate what is the susceptibility of different age groups in the population. And as you can see on the left-hand side, that's the susceptibility of 0 to 20-year-old children relative to 60-year-old children. 60-year-old individuals. And we estimate roughly 23%. Relative susceptibility, and for individuals between 20 and 60 years, the susceptibility is 60%. If you assume that 100% is the susceptibility of 60-year-olds individuals. And that's compatible roughly with what's seen in other studies, and that's one of the specific studies that we used, from which we used the prior information to estimate our parameters for the susceptibility. The probability of hospitalization increases almost exponentially with age, as you can see in this graph. So the scale, the Y scale is actually logarithmic, and the X scale shows different age groups. And you can see that it's almost a linear line. It's almost relationship is almost linear, except for these 2 young age groups. So the probability of hospitalization overall varied a lot, and it was 0.1% for the youngest age group and almost 4% for the oldest age group. That's how the model fit looks like to the hospitalization data. So the different panels show the different age groups. In the top row, so this is for the 0 to 20-year-old and so on, progressively to the oldest individuals, 80-year-old, and the Y-axis shows the number of new hospital admissions per day in a given age group. And the red dots are obviously that's the data, and you can see that there are fewer hospitalizations in younger individuals, so that the pattern is not so clear. But in the oldest individuals, you clearly see how the wave developed. And the solid line, the solid black line, is the median trajectory from the model, and the gray shaded region are the Bayesian prediction intervals. So we have a fairly good, or really good, I think, the prediction for the hospitalizations, and also we fit the model to the seroprevalence data, which is shown here after the first wave. So the bars show the data, and the dots, they show the data in different age groups, and these violent plots are distributions obtained from the model, and you see that everywhere our model predictions mainly lay within the confidence interval of the model. There was not big relationship or big difference in terms of seroprevalence in different age groups. It was slightly lower in younger individuals and a bit higher in the middle age groups, but overall it was just a few percent. So then we look at impact of the public health control measures. And if you make it really simple, so the aim of all these control measures, as all the TV channels now say that we want to keep the effective reproduction number below 1. That's basically what means control of the pandemic. So we want that stays below 1. It means that we will not have, again, exponential growth rate, and we will not have a new outbreak. So the effective reproduction number, I guess probably most of you know, but that's just the average number of new cases one infectious person would generate during its infectious period. And the subscript E, or effective, it means that there have been already some measures in place. So not all of our population is fully susceptible anymore. So we distinguish between two types of interventions. We look at the interventions that are targeted at children, so those that can change the school contacts, or schools within contacts within schools, or interventions that targeted at the rest of the population. And here I attached just a schematic of this Dutch pandemic that we made. As you can see in the there's bars of different colors. They show interventions. For example, the light green color, it means that the schools were open, and the dark color, that means that schools were closed. So the pandemic started at the end of February, and we estimate this should be actually R0 of 2.7 roughly. At the beginning of the pandemic, and the schools were all open, but in the mid-March schools closed, and they stayed closed during roughly most of the period. It was a very short interval when they just opened in summer before closing again for the summer break. And then after the summer holidays, schools opened completely at the end of August, and they stayed open until our study was basically submitted and published. So, and there were also other interventions that were taking place, of course, and at the same time when the schools were closed, there were a lot of non-school interventions, and then they were slightly released through the summer, and then increased again when schools opened. And we estimate also the RE value from the model, which I didn't show, but that's numbers stay here. So during the most stringent lockdown, RE was roughly 0.6. So this is after in April. And then when schools were opening, RE was already 1.3. And due to interventions in the rest of the population, because schools were open, that was reduced to 1 by the end of November. So in our study, we do analysis. We consider several scenarios. And the scenarios include decreasing either school contacts, while we keep the rest of the contacts in the society fixed, so we don't change them. We assume that the interventions only target schools, and they can be all range. So you can change this number of contacts by introducing measures like isolating individuals or children at school who identified positive, or completely closing schools. That's the most drastic measure. And then we also include another scenario in which we keep the schools open as the society overall wanted in the Netherlands, but we introduce more measures that would decrease non-school contacts in the rest of the society. And we assume that these contacts, they can be reduced maximum to the level of April 2020, which is the level of the first lockdown, which was the most stringent lockdown. After that, it hasn't been possible to actually to have more strict measures in the society. And we I will present you 2 time points. So August 2020, when as I said, RE was already above 1 and schools just opened, and there was also a relaxation of the lockdown in the rest of the society. And when RE was already 1 at the end of November, schools were still open, but we already in the second lockdown, and it was absolutely not clear how you can still reduce, get the control, so get the RE lower below 1. By introducing any measures, because the measures in the rest of the society, they were not working enough, and but schools were also not closed. So here are the results. As you can see, that's the effective reproduction number, and this is the reduction in other contacts in society. So these are non-school contacts, and we start with the point 1.3, which corresponds to the moment when the schools were opening. RE was around 1.3, and by reducing these contacts to the level of April 2020, which is the lowest reduction possible, RE could reach roughly the minimum value of 0.83 if that would have been realized. And at that point, it was still necessary to reduce contacts at least by 60% to get the control of the pandemic. And the control of the pandemic is described by a value of RE close to 1. At the same time, if schools would not open in August 2020, so we start with exactly the same value of 1.3, but the contacts in schools would be decreased from 100%, so from schools being completely open, and if they would be reduced by 100%, so the schools would be completely closed at that point, we see that the impact on the RE would be much smaller. So before it was, you can see that there was a relatively large drop if you would be still reducing non-school contacts, but if you would be reducing the school contacts, the RE would reduce only by 10%, and most importantly, it would still be above 1. So the conclusion is that, well, while, of course, targeting these measures at schools at the end of August, while it would have some impact on the pandemic, it would reduce the number of cases, but the RE wouldn't still be decreased to below 1, and so this measure would not have prevented the second wave in autumn. Well, if you look at the November 2020, when the RE value was already 1 as shown here on the y-axis, and we also look at the reduction in other contacts in society or reduction only in school contacts, the relative impact that you can achieve by reducing either contacts in the rest of society, if you reduce them to the level of the first lockdown, or if you reduce the contacts to the level, if you close schools completely, that would be very comparable. And both of these measures could have helped to achieve control at the end of November. So the impact of schools overall depends on what are the rest of the measures that are being taken in society. Then we looked separately at different school ages, and this would be the impact in different panels. You can see the impact on RE of closing schools or reducing contacts in schools for different school ages. So for example, 0 to 5, 5 to 10, or 10 to 20-year-olds. And you see that you can reduce contacts in 0 to 5-year-olds almost completely, and it has almost no impact on RE. But if you reduce contacts among the 10 to 20-year-olds, then you can have quite some impact basically, and this impact is the largest among all of the 3 groups, and it's basically almost I think it's more than 60% of the total impact that can be achieved by targeting interventions in schools. So the conclusion for this is that, well, first of all, the interventions in the first place, they have been targeted at all the school children. These school children, they have, not only they have the largest number of contacts, but they are also most susceptible, as I showed you before. Then closing schools after the summer break in autumn 2020 would not have prevented the second wave. That was what I demonstrated. And also the impact of measures that reduces the school-based contacts depends on the opportunities to reduce non-school-based contacts. So if the RE is close to 1, you can still expect to have quite some impact with introducing measures in schools. But if RE is very large, then the impact will be very small. Now I will move on to the second study. Well, maybe we can ask, I would like to ask, maybe somebody has already some very questions that he would like to ask immediately. Maybe raise your hand so that Myra can see you and unmute you.
There is 2 hands raised. Just a minute.
Okay.
Vanessa, we'll promote you as a panelist. Georgie, from first, please.
Hi.
Hi.
Can you hear me?
Yeah. We can hear you. Yeah.
Can you hear me?
Yes.
Yes.
Could you please come back to the other slide, the last one?
Oh, the which slide? The one? This one? No.
Can you? Not the first. The last one.
Oh, the last slide. This one?
With the graphics. Yeah. My question is, with the difference between the ages.
Did you like the content of this channel? So please subscribe to the channel. It's quite simple. You just have to hit subscribe, and you can decide which level of the notification you want. You may choose all the notification, which means that everything that I do, you receive a notification on your bell here on the upper corner, or you can choose no notification. I would strongly recommend you to subscribe, even if you don't want to receive all the notifications. Just hit here, no notification, or hit the one that you like the most. It's pretty important that you subscribe to the channel so I can achieve a high number of subscribers, and people can as well understand that this channel has a nice content to offer, and YouTube will understand as well that it can make a nice divulgation of the channel. So please subscribe to the channel.